Good morning, everyone. My name is Sai Wui. I'm the clinical pharmacist covering UMMC. Today, I will be talking on the medications in managing chronic kidney disease. Okay, these are the concerns managing CKD patients. There are average of 8 to 12 medications daily requiring multiple doses per day, and their regimens change frequently. Average of 3 to 5 comorbidities like heart failure, diabetes, coronary heart disease, hypertension, and dyslipidemia in CKD patients are very common. So any change in drug excretion due to renal failure can increase the risk associated with these medications. So what are our objectives in CKD complications is to reverse or to stop the process causing the renal damage, avoid conditions that might worsen the renal failure, relieve the symptoms, and also implement regular dialysis treatment or also transplantation at the appropriate time. Okay, so anemia in renal disease. What is our management for anemia in renal disease? First, we have to identify and correct or treat the underlying causes of the anemia, ensure adequate iron and nutritional supplementations. Blood transfusion is reserved for patients who are symptomatic and need rapid correction. Erythropoiesis stimulating agent like ESA is also one of the management for anemia in CKD patients. So ESA, what is it? It's a recombinant human erythropoietin that is given by either intravenous or subcutaneous route. It can increase the erythropoiesis through direct or indirect action on the erythropoietin receptor. So the examples of the ESA agent that are available in our hospitals are Recomon, epoetin beta, Aranaps, dabipoetin alpha, and also Mircera, methoxy polyethylene glycol epoetin beta. Okay, so these two are the short-acting ESA agents that are available, but Eprex is no longer in our hospital because it has been removed. Okay, so Recomon and Eprex, the dosing is 50 to 150 IU per kg per week in 1 to 3 divided doses. And our target is to achieve HB of 11 to 12, but not to exceed 13. Next will be the dabipoetin alpha, Aranaps injection. This one is a slightly longer acting ESA agent. Okay, it can be given once every 2 weeks, also through SC or IV. The dose is 0.45 mcg per kg per week or 0.75 mcg per kg every 2 weeks. Next will be the longest acting ESA agent, which is the new class of the continuous erythropoietin receptor activator. This one can be given as a once every 2 weeks dosing or monthly dose. Okay, so what is the mode of administration? Okay, all the ESA agents can be given either subcutaneously or intravenously, but we always allow pre-filled syringe to reach room temperature 15 to 30 minutes prior to using it. And then it is a sterile, single-use pre-filled syringe. Any missed ESA dose should be administered as soon as possible. So for the storage and stability, it is to be stored at the 2 to 8 degrees Celsius. Okay, so you have to store it at the refrigerator. Do not freeze or shake it. And then it may be removed from the refrigerator and stored at the room temperature, but not more than 25 degrees Celsius for up to 3 days for Recomon and for 7 days for Aranaps. Mircera, the longest acting ESA agent, can be stored at room temperature of not more than 30 degrees up to 30 days, but once removed from the refrigerator must be used within 30 days. So all this, we have to keep it in the container to protect from light. Okay, so what are the common side effects? The common side effects are worsening of hypertension, which is the most common. Around 10% of them will have this side effect. So for patients where the BP is more than 180 over 100 on that day, we do not inject the Recomon or the Mircera or the ESA agent, we do not inject. And then some of the less common side effects includes like seizure, access thrombosis, and this pure red cell aplasia, which is a rare side effect, but it is a serious and life-threatening side effect. Okay, next we will be talking on the iron agents. Okay, so oral iron, of course, is the safest and also inexpensive iron agent. The starting dose is at least 100 to 200 of the elemental iron daily. Side effects includes constipations, dyspepsia, black stools, to be taken before food, empty stomach, because the acidic environment makes it easier to be absorbed. So usually we encourage the patients to take it 30 to 60 minutes before meals or 2 hours after meals. Or we can prescribe together with vitamin C so that we can provide the acidic environment for good absorption of the ferrous. Bear in mind that all these iron agents actually interacts with phosphate binder, so we should always advise the patient to space the administration time between these two drugs of at least 2 hours. But for oral iron, even though it's safe and it's inexpensive, but it is poor efficacy in maintaining the target HP and also the iron levels in the HD patients. Therefore, we have this IV iron. Okay, IV iron has a superior availability and efficacy when compared with the oral iron. So these are the IV irons that are available in our hospital. Iron dextran, the brand name is called Cosmofer, and iron sucrose, Venofer. So iron dextran allows for intramuscular administration and a total dose infusion of up to 20 mg per kg. However, it has higher risk of life-threatening adverse drug effects compared to iron sucrose. And we also have this IV monofer, which is the latest, newest agents in our hospital. It's called iron isomaltoside. It's available in both strengths of 500 mg per 5 ml and 1000 mg per 10 ml vial. So these are the simplified table where you target the patient's HP and also you dose according to the patient's body weight. Okay, so some of the patients, as you can see, if it's less than 50 kg, then we dose 500 mg. Then if it's 50 to 70 kg, we dose higher dose. And then if patient's body weight more than 70 kg, then we dose even higher. So it follows the patient's body weight and also the target HP that you want to target. Okay, so for the administration wise, it can be given by slow IV injections or IV infusion. It can administer a single dose up to 500 mg, either undiluted or diluted at a maximum rate of 250 mg per minute. For total dose infusion, we can administer dose up to 1000 mg over more than 20 minutes, administer dose more than 1000 mg for at least 30 minutes. So the total dose infusion time is so much shorter compared to the IV Cosmofer. That's why it is very suitable for outpatient setting, because the patient do not need to stay at the daycare for so long just to infuse this IV iron. Then the single infusion up to 20 mg per kg can be administered, but not to exceed 1500 mg, and then the cumulative dose of more than 20 mg per kg of the iron must be divided into 2 doses and administered at least 1 week apart. All these iron agents should be avoided during the first trimester of the pregnancy. The side effects includes anaphylaxis and also infections. Allergic reactions can be managed with IV fluids, hydrocortisone, or any antihistamines. And overdosage of the iron, okay, which cause the acute iron overloading, can be treated symptomatically or with an iron chelating agent like desferrocetmine. Okay, next we will be talking on the renal bone disease. Okay, so what are the medications used for managing renal bone disease? First, phosphate control. Okay, dietary phosphate restriction is the first step. Doctor will always prescribe phosphate binding agent, okay, we call it phosphate binder, okay, to lower the intestinal phosphate absorption by creating poorly soluble complex of phosphate in the intestinal tract. Type of the phosphate binding agent available is the aluminum-based one. Generally, it's not used anymore because due to the risk of aluminum toxicity, but in some of the center, aluminum-based phosphate binder is still in use. If used, then we have to make sure that we do not exceed 2 to 3 grams and only for short duration and not to exceed 4 weeks of duration. This is calcium-based phosphate binder is the most commonly used phosphate binder. Okay, it's calcium carbonate is the best example of the calcium-based phosphate binder. It can be administered with meals, phosphate binder, and also it is a source of calcium. So this calcium carbonate now in our hospital is available in the capsule form. So we always advise the patients to open up the capsule and then sprinkle on the food when they take it. And then total of 6 grams of elemental calcium should probably not be exceeded. And then the dose is titrated according to the amount of the food eaten. Larger meals require larger doses of the phosphate binder. So there's no standard dose for everyone. It depends on the meal size, then the dose is different. The next phosphate binders that are available in our hospital is the non-calcium or aluminum binders. The example will be the sevelamer hydrochloride, Renal gel, or carbonate, Renvela. Okay, the dosing will be 1 to 2 tabs of the 800 mg tablet with meals 3 times a day. The main side effect is constipation. and is contraindicated in patients with bowel obstruction. Next will be lanthanum. Lanthanum is also a non-calcium based phosphate binder. So it can be taken with food, okay, which forms lanthanum phosphate. It does not readily pass through the lining of the GI tract into the blood. So that's why the phosphate absorption from the diet is reduced. Okay, so this is the dosing for the lanthanum, 750 to 3000 mg in divided doses to be chewed with or immediately after meals. Then less hypercalcemia occur, however, it may develop hypocalcemia because it does not contain calcium. And it also may increase the gastric pH, therefore drugs that interact with antacid like ketoconazole, hydroxychloroquine should not be taken within 2 hours of Renal. Okay, the next one will be calcium control. Okay, so calcium supplement like calcium lactate is commonly calcium supplement prescribed. Vitamin D analogs can also use to help with the calcium control, because even with the dietary compliance and phosphate binders, hyperparathyroidism occurrence is still high. So calcitriol deficiency is an important cause of the HPTH, so vitamin D is important, but those should be limited because it may induce hyperphosphatemia and hypercalcemia. So calcitriol is the most commonly available vitamin D analog, which is a synthetic calcitriol. It's the most important active metabolites of the vitamin D3. The total daily production is around 0.5 to 1 microgram in normal patients. So it promotes intestinal absorption of calcium and regulates the bone mineralization. So patients may be maintained on a lower calcium intake. So the effect of a single dose of calcitriol lasts about 3 to 5 days. So patients with normal or only slight reduce of the serum calcium, the dose of 0.25 microgram alternate day is sufficient. So if hypercalcemia is noted in that patient, calcitriol should be discontinued until the calcium level comes back to normal. The side effects includes nausea, vomiting, altered mental status, abdominal pain, weakness, and weight, muscle, and joint ache. Okay, alpha calcidol, or we call it 1-alpha, is available as capsule of 0.25, 0.5, or 1 microgram, and it looks like this. Okay, it is converted in the liver to become the activated form of the 1,25-dihydroxychlorocalciferol calcitriol. Next will be cinacalcet. This cinacalcet is also available in our PharmUMC, but the patients need to buy. So it helps to treat the secondary hyperparathyroidism. Starting dose is usually 25 mg OD, and the dose may be increased within a range of 25 to 75 mg once daily. If no improvement found in the PTH level, the dose may be increased up to 100 mg OD, and the dose should be increased by 25 mg at a time at intervals of at least 3 weeks. So what are the monitoring parameters for patients starting with cinacalcet? Is the serum calcium level. Prior to administration, have to make sure that the serum calcium level is less than 9 mg per deciliter or 2.2 millimole per liter, and also the PTH level after starting of the cinacalcet. So how does it work? Cinacalcet decreases the serum PTH level by acting on the calcium receptor and mainly suppressing the PTH secretions. Okay, so the next one will be sodium bicarb. Okay, sodium bicarb is also commonly seen in CKD patients. Doctor usually prescribe sodium bicarb because metabolic acidosis is a common condition in CKD patients where there is an acid-alkali imbalance in the blood, so results in high blood acidity, the low pH, and low plasma bicarbonate level. So bicarb supplementations with sodium bicarb can slow the progression of the CKD. So in our hospital, it's available in both the syrup and also the tablet form. Okay, so this is the tablet form, okay, of the sodium bicarb available in PharmUMC. Patient also need to buy because it is available in a special formulary. So 10 gram contains around 650 mg of the bicarbonate. So this is the treatment algorithm in our hospital for metabolic acidosis in CKD patients. Okay, so the next one will be sodium bicarb syrup. Okay, sodium bicarb syrup is available in 1 gram per 15 ml strength. So the usual dose will be 10 to 15 ml 3 times a day. Okay, that's all for my presentation today. So thank you very much.